Good morning, Suzanne.
Hi. How am I sounding in there? Am I loud?
Um, a little, but it's just me and you, so it's okay.
Okay.
And Dr. Forky is right there. You can say hi.
Hi, good morning. Hey, good morning. It's funny, we're all in different places, but this is going to work just fine.
Sounds good. All
And
set.
Emily, I think I saw that Dr. Weister is going to do the intro, right? I'll just bring us to order. Is that right? And
That
then
is
I'll help
right.
with the Q&A. We have time. Okay, got it.
Perfect.
I'm all over
Yep. And if anyone does come to right, I'll jump in at Q&A just to see if they have questions.
it. Okay, great. Text me if they do so I can make sure to look for you.
Yeah,
Thank
I will do that. And so I think we're all good. We're getting close to it. So,
Great. I don't see Becky on here yet, although maybe she's one of the cell phones.
well, and we
But I'll
talked we talked a couple of
see.
times yesterday, so I know she's ready.
Sounds great. Awesome. Hi, Dr.
All
Forky.
right.
Thanks for being here.
Yeah, my pleasure. Thanks.
Seems like you have a big day ahead of you, so we're so excited.
Yes. Yeah, I actually, this is my second lecture of the day already. So
Wow.
and then I saw patients and now I'm back to lecturing. So it's a really busy day.
Oh my gosh. Where are you on the East Coast?
Yeah. So I'm in Worcester, Massachusetts. So
Got it. Okay. Because that would be very impressive to do from here since it's 8 a.m. for us right now.
Yeah.
It's still impressive.
Yeah.
All right.
I woke
It
up
looks
this
like
morning. I'm like, how did all that wind down one day? All of
I
that.
know. That's how it works. Hi,
It is.
Dr. Weister. She's getting there. She's coming on. She's looking for the unmute button. I can see that. I can see it in her face. Mine's on the bottom.
You know what, guys? I can put my cell phone in on the chat. I can't see, like, if I get disconnected from you, I can't see that. So in case there's some major glitch and you guys are like, wait, what? I can just have you guys call me and say you're talking to no one. Or I could just tell it to you if that would be easier, whatever is best for you.
In case you don't want to put it for everyone to see, you can just send it to me or Emily.
Okay, let me do
And
that.
Becky, did you get your sound working? I haven't heard your voice yet. Nope. I can see you're talking, but I can't hear you yet. We got to fix that. We might need Jacob. Oh, she's calling in on her cell phone. Gotcha. Thanks. Heather, I have your number.
Okay.
I'll take a picture.
Okay, how about now? Now?
Yay!
Can you hear me?
We hear
Okay,
you.
yeah.
Yes. Thanks. I
Yeah,
could
just
see it on your face.
twice.
Like, oh no.
Twice. It's always WebEx. You know, Heather, when you said it's a pain
Yes.
for years now. WebEx, Zoom, everything's perfect. But anyway, so I'm here. Good.
Weird. I don't know why we're so
Welcome.
tied to the WebEx. Okay, great. Ah, thanks for being here, Becky. I'll bring us to order at 8, and I can handle the chat. And also, if Heather gets disconnected, I will. I'll call her.
Find me again.
I'll tell everyone to hold on, and we'll call. But so far, it looks like everything's working fine. We have a big crowd already, so we'll get started in like 2 minutes.
Good.
Thank you.
Okay.
This is great. This is awesome. Thank you so much.
So Heather, I was going to tell you. So Suzanne's going to introduce the thing. I'm going to introduce the kind of grand rounds, and then I have one tiny little acknowledgement for a very important person I have to do. So forgive me for 3 little blurbs.
Sounds great. No problem at all.
Okay, great. All right, thanks.
Just waiting for my clock to switch over to 8 a.m. We have a great crowd already, so it's awesome. All right, it did. Good morning, everybody. Welcome to Pediatric Grand Rounds. Thanks, everyone, for being here. I think most of us are on WebEx today. For those of you who are on WebEx, please use the chat with everyone feature to enter any questions or comments you have for our speaker, and I will share them with our speaker at the end of the hour. And then just finally, a disclosure from me, the planners for Grand Rounds have no financial relationships to disclose. And from here, I will turn things over to Dr. Becky Webster, who's going to introduce our lectureship and our speaker for today. Thanks, everybody.
Good morning. This is the annual Holt Webster Grand Rounds, which is dedicated to the topic of child abuse and neglect. This Grand Rounds has been made years ago from the generous donation from Holt and Kate Webster, who were well-known and well-loved philanthropists in the Seattle area, and we thank them for this great gift. I'd also like to take a minute to acknowledge and thank the former and first program director of our child abuse program, Carol Jenkins. She was a friend and colleague to so many people in this audience, and she had the spark and the genius and the generosity needed to create this whole program and send us forward. She will be sorely missed, and we want to thank Carol. So now I'd like to introduce Dr. Heather Forkey, who joins us today, and we're so glad to have you here. Dr. Forkey is joining us from the University of Massachusetts Penn Medical School. She's nationally recognized expert and author on the treatment of childhood trauma and the advocate for child and family trauma-informed care. She's known to many of us through her work through the American Academy of Pediatrics and to us from her collaboration with our own Harborview-based foster care center of excellence. So thank you so much for joining us, and we'll let you go right ahead. Thank you.
Well, thank you. Thank you guys so much for having me. I'm gonna try sharing my screen. We'll bring up my slides, hoping you guys can see them. So I am delighted to meet you. I wish I could be with you in Seattle, but it sounds like all of us are kind of zooming in, or however we're coming together. We're going to talk about trauma-informed care that is possible, practical, and productive. Before I start, I just need to let you know I do get some book royalties from a book that I have published with AAP Press, but otherwise nothing else to disclose. We're going to talk about trauma-informed care, and specifically, I hope by the end you can implement some strategies to set the stage for trauma-informed care and create safety in the pediatric hospital or outpatient setting. You'll be able to choose surveillance and screening strategies that you can implement easily, and when they are done, you have some clinical direction for yourself and for the families you're caring for. And we'll talk about some techniques so that you can address trauma symptoms in the office or the hospital setting. I will say right now, if people ask about trauma-informed care, they come away, I think, with an idea of something fairly abstract. They're not quite sure what to do. And I will say SAMHSA did us new favors when they tried to define what trauma-informed care was in 2014, because they created this lovely graphic, but it's pretty vague. I mean, it has some pretty important concepts in it, but it looks like abstract art, and it comes across as abstract concepts because how do you actually implement all of those wonderful things? Alternatively, I will say there is a big push, especially for you guys on the West Coast, to do ACE screening and define that as trauma-informed care. But I would suggest to you, and we're going to talk more about this, that that is a very narrow and probably not the most effective way to provide trauma-informed care. And yet, the patients that we care for have a host of issues that are related to traumas. We know that early significant relational trauma is associated with many, many diagnoses, and I'm not going to read through the slide, but you know that you're seeing every day patients that are presenting with these symptoms, and you need to understand how to address them with this trauma-informed care lens. I will suggest to you that we see them all the time as well. JR is a young man that we saw and was inpatient in our children's hospital here at UMass. JR is like many of the kids that we are all caring for, a young man who came in because he was in a congregate care setting. He's in foster care. He's suffered significant abuse and neglect. He had some externalizing behaviors in the group home and was admitted to get placed in an inpatient psychiatric facility. And while he was there, things were actually going quite well. But one particular afternoon, his lunch tray came up. And now JR had this habit of putting bags of Doritos in a corner of the room. And he had hoarded quite a few bags of these Doritos in his room. And on this particular afternoon, the lunch tray came up, and on the lunch tray was a big piece of cake in addition to his food. And a well-meaning hospital nurse told JR that he couldn't have the cake until he ate the other healthy foods, although JR was going right for the cake. And she told him to eat the other food first. He refused. She said, well, if you don't eat the cake, if you don't eat the healthy food before your cake, we're going to have to take away your Doritos. And when she said that, JR tore apart the room. He completely lost control. And by the time things were done, the room was destroyed and 2 staff members had been injured. Another case that you might find familiar is a case of Cleo, who came to our outpatient clinic, and she was there because she had an asthma exacerbation, which we're seeing a lot of as the weather changes here in central Massachusetts. But Cleo's parents, after kind of addressing the asthma issues with the caregivers or the pediatrician, said, we're really concerned because she's not really sleeping well. And that the clinician said, well, if you're giving her a lot of albuterol, then that's not uncommon. And they said, no, she hasn't been sleeping like for a while now. And we're all up, and we try to be firm with her, but eventually we're also exhausted that we're just sort of letting her sleep in our bed. And so the pediatricians sort of addressed what they identified.
Don't need to be sorry.
I don't know if somebody needs to put their on mute, but so what she found was that they sort of thought that the parents were just not being consistent with rule setting. So this is how we handle the kids, right? We look at the kids, and for JR, the residents wrote a note that the nurse was angry or the child was angry that the nurse took his Doritos. He acted out when she took them. There's been no new meds, no other recent stressors. He's otherwise awaiting placements. They did an exam. They identified that his hand was swollen and hurt. They x-rayed it. They found a boxer's fracture. Their assessment was that he had DMDD, possibly PTSD and ODD, but they really wanted psych reeval and possibly getting him on a mood stabilizer immediately. Similarly for Cleo, they kind of got this history about the fact that she wasn't sleeping, and she doesn't want the parents to leave the room. They tried to be consistent, but they often give in because no one's sleeping. They talked about sleep hygiene. On her exam, she had maybe some tonsillar hypertrophy, which sort of raised the specter of possibly some obstructive sleep apnea issues. She had the asthma findings on her chest x-ray. And so they identified this as a parental consistency issue and reinforced that consistency. And so this is really how we handle it. We kind of do these SOAP notes. We take subjective information. We get some of our own information objectively with labs and exam. We then put these pieces together, and then we come up with a plan. But how would trauma-informed care be any different from the things that we already do? And I think that's what we really need to talk about. How do we incorporate trauma-informed care into protocols that we're used to and forms that we're used to? Because we don't want to completely do something totally different, but we need to think about some things that are totally different. And so one of the things that we need to think about is a really interesting concept that humans from birth have really 2 jobs. Our 2 jobs are to get our needs met through others, through seeking the support of others, and to keep ourselves safe. So we've got this enormous neurologic, endocrine, and immune circuitry, which is designed to balance these 2 things: social connectedness on one hand, and dealing with threats or getting needs met, right? Bottom line, that's what humans do. And we do that from birth. We do that all the way through our lives. Those are the 2 main things. And we have all this ability to use the way we're made so that we can do these successfully. In fact, one of the concepts that we're going to talk about is neuroception, because we are constantly scanning the environment for threat. You think you're listening to me, but if there's a loud noise where you are, or lights began to flash, or the ground began to move, or a funny smell, immediately your attention would be diverted. You are actually constantly scanning the environment for threat. And we have a number of stress responses to those threats, right? We can freeze, we could just stay still. And this is sort of the most primitive stress response. And it's actually not all that useful for humans, right? Because we're sort of big. So if we just stand still, predators tend to find us. So we're not like a possum or a mouse who can stand still and the predator can miss them and go right by them. For us, it's not that useful. We use it, but it's sort of a last resort stress response. We evolved to have a more effective stress response, which is fight or flight, so that under threat, we can run away from the threat or we can turn to the threat and try to fight for our lives. But again, humans are not that good at this compared to other animals that we are around, right? We don't have claws, we can't hide underwater. If you're a child or you are a caregiver with children with you or you're pregnant, you can't fight or flee very effectively. So again, not our best shot. And in fact, if it was just that we only had freeze and fight or flight, from an evolutionary standpoint, we would have been lost we wouldn't be sitting here, right? Because that's not what we're most effective at. As humans, our most effective tool is our brain and each other. And it turns out that we evolved to have this other stress response, which is called the affiliate response, or tend and befriend. And this is actually the one that's most effective for us humans in most circumstances, right? Under threat, what I do is I look around me and I say, are there other humans here who can help me manage this threat, this challenge that I have? Kids turn to parents, we turn to colleagues, and we say, hey, can you help me with this? But here's the interesting thing. This is oxytocin mediated, but oxytocin doesn't make me better at affiliating. It actually makes me better at recognizing whether people will help me or not. That's called increased social salience. And so I look left and right and I'm able to draw clues from how that person's face looks, what their vocal tone is, what their body posture is. And I can identify whether this is someone who will help me, whether this is a safe context. And if you think about it, from an evolutionary standpoint, that was the critical thing, right? If I turn to someone and I assume that they're not going to help me, they want the same saber-toothed tiger or they want the same cave, and I don't go and seek their support, okay, no harm, no foul. I have a harder time getting what I need. But if I assume that they're friendly and they do want this, they might kill me too. And so it turns out that the people who are really good at assessing who can I gather to me are the ones who survived. The people who didn't have that skill, they came out of the gene pool, right? They were killed. And so what happens is that once you identify this sense of safety in others, is that you develop pro-social thoughts and actions, which makes you better at gathering people toward you. And you develop adaptive stress responses, your cortisol drops, your adrenaline drops, and you manage the threat. But if you recognize that that other cave person wants what you want and doesn't want and is willing to fight you for it, you've begun to recognize that you now have two problems, right? You have the original threat that you needed that support for, and you have a second problem. So you have to develop antisocial or defensive thoughts to protect yourself. So now you have this abundance of adrenaline and cortisol, and you have to look at these other people as threats to you. So you develop these distress responses. And interestingly, I'm going to blow your mind with another concept. We are the only species, only one, that actually can learn from each other about the threats out there, right? Not even our closest evolutionary, like other apes or primates, can converse with each other and say, hey, don't go to that part of the woods because that's where the lions live. Only humans can do this teaching. But in order for us to understand and learn from each other, we have to do two things, and it has to do with affiliate response. I have to believe that you have my mind in mind when I go to you with a problem, that you are looking at my problem with my perspective, that you're not going to do this in self-interest, but you're going to do it with my interests in mind. And that is this concept of mind in mind and what it builds. If I see that you will help me and you're looking at the problem with my perspective, we develop what's called epistemic trust. Epistemic means learning. It allows me to learn from you. It allows me to take the information you give me, trust it, and go from there. We're going to come back to this concept, but this is critical. If you think about where we are as a society today, we have a lot of people who don't trust medicine. They don't believe that we have their mind in mind. And so they are not willing to learn from us. They are not willing to get vaccinated. They are not willing to do the things that medicine says because they think ultimately that we are not looking at the world with their mind in mind. Okay, so what happens is if I can't use affiliate, I've got no choice. I use fight or flight. Plus, I'm more antisocial because I've got this extra problem. And that is what leads to a lot of these health consequences that were brought up in the ACE study, and that you've, I'm sure, heard a zillion lectures about, that we have consequences from this inability to use the affiliate response, which is the fundamental definition of trauma, is that I'm locked out of using those supports from my caregivers or from others. And so I overuse fight or flight, and that has immune and endocrine consequences. It has cardiovascular consequences. It changes my microbiome, and it most certainly changes how the brain develops in children. And here's one more point I want to bring to your attention. You know, when people talk about trauma, a lot of times people say, oh, that diagnosis is post-traumatic stress disorder. But trauma actually, like every other insult to the body, results in a spectrum of consequences to humans, right? So you can have a trauma that's mild or that is with support, and you can have mild responses, right? Functional difficulties in sleep, see small changes in behavior, issues with toileting, issues with eating. If the trauma is more severe, you may have those functional difficulties and these post-traumatic stress disorder symptoms that you're all familiar with: arousal, avoidance, re-experiencing of fear. But what people forget to talk about is the fact that early interpersonal trauma, this early inability to use affiliate support, can result not just in functional difficulties and post-traumatic stress disorder, but it can also go on to cause what we call developmental trauma disorder or complex trauma. And this is impacting humans at multiple levels. It's affecting their affect, right? They become much more violent or self-destructive. They can also not externalize, but internalize, shut themselves into themselves and dissociate. And certainly this constant kind of trying to keep themselves safe results in attention issues. But it also changes how they understand themselves and how they understand others. And this is entirely related to that lack of affiliate support, right? They begin to develop a sense of themselves as diminished, defeated, worthless. They have this sense of shame and guilt, and they can't interact with others in healthy affiliate ways. You know, this result is a result of how we come to understand ourselves. I mentioned to you that addressing fear is a primary task of humans. And so children, all humans, come to understand themselves and the world through these relationships with others and the safety they find in others. You know, if a baby cries and the caregiver hears that cry and says, oh, baby, you're hungry, that baby learns something about the world and about themselves. They learn, this feeling I have, that one's hunger. And if I cry, if I can communicate my needs, and people will come help me, and I am worthy of being helped. If a toddler is trying to do something and they are frustrated and the caregiver says, hey, buddy, you're frustrated, that child learns this feeling is frustration. I can get help when I need it. People will help me deal with this. I can learn and go forward. Contrast that with a child who cries and a caregiver who's overwhelmed by mental illness or substance misuse screams at that baby, oh, would you just shut up? You're so damn greedy. That child learns something very different, right? That child learns this feeling, that one's being greedy. Nothing you can do about it. There's nobody who will help you, and you're not worthy of being helped. And when they're a frustrated toddler and the caregiver says, what are you, stupid? You can't figure it out? They learn that that feeling is being stupid. There's nothing you can do about it. You're not worth having anybody do anything about it. And there's no way to fix it. You can't get around it. So that child is creating a map of themselves and the world based on this fear and this inability to connect and use affiliate supports. Trauma fundamentally changes how you understand yourself and others, fundamentally because you have lost that sense of safety achieved through the affiliate response. And that concept is so critical that we use it all the time and we don't even know we're using it, right? So I'm sure you guys have talked about toxic stress, right? And you talked about how all of these adversities can lead to toxic stress. But if we focus just on the adversities, we miss the most important part of this definition, right? Toxic stress is the result of that adversity on the body if it is not buffered by supportive relationships, if you are not able to use affiliate supports. And so I would like us to sort of just shift our attention as we think about providing trauma-informed care for JR and Cleo and everyone else that you're going to serve, and think about how do we push our patients back to using affiliate? How do we provide trauma-informed care, which means that we are also going to call this relational health care. And so we're going to think about this as fundamentally, how do we re-engage the affiliate response in our patients and our kids and our families? And we do this with kids and families. And I say with, and I accentuate my word because I'm actually using it as an acronym. And those of you that know me know that I'm an acronym. I love them. I love them in an unhealthy way. So everything I do, I put an acronym in. So trauma-informed care is with affiliate support. And with stands for wondering together, investigating, treat, and hope. So let's walk through this together real quickly. Let's go back to JR, right? We took a history. We got some subjective information from him. But what we also did not attend to when we took that history is that he apparently was demonstrating that he did not feel safe in this situation. He was showing us that he felt that he was showing this distress and he was acting in an antisocial and defensive way. So he clearly had some of his perception of threat triggered, right? Neuroception is this sixth sense that we have, which is actually not a sixth sense at all. It uses sight and sound and smell and all of our senses so that we can perceive threat. But we in healthcare can show patients either threat or safety. And we do that first by wondering together with them. And when we wonder together, we're demonstrating curiosity, acceptance, respect, and empathy. And so you guys are like, Forky, I got up at 8 o'clock in the morning to listen to you tell me to be curious, accept, respect, and empathy. Come on, like I went into pediatrics because this is what I do. Yes, I agree. But let's talk about how the patient feels all of these things from you, right? You have to project that sense of safety. And how do you do it with your vocal tone? Well, it's the tone of voice that you use. If you come to me and you say, I am not going to eat my healthy food, I am going to eat my cake. And you respond by saying, oh dear, it looks to me like you're very upset. People do not feel heard. We need to match the intensity of their response with our response, right? If your friend calls you and says, oh my gosh, you would not believe the horrible day I had, you're not going to respond to your friend and say, oh dear, that seems very terrible. No. Your friend would be like, you're not hearing me. You match their intensity, but what we can do for patients is match the intensity and walk it back. Hey, I understand you want that cake. I love cake too. And you know what? Let's think about what we could do so that we get maybe a bite of cake and you walk them back. You match the intensity and you walk them back without the anger. The other thing that you're doing is you're modulating your tone of voice, right? We know that low pitched sounds are sounds of danger. So if I sing for you, and I apologize, I sing terribly, but if I go doo 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 doo, you can understand that I'm singing the Jaws theme, hopefully, and you understand that that must be a scary movie because low pitched sounds are sounds of danger. That's why composers use low pitched musical instruments when they're sending a message of danger. High-pitched musical sounds are sounds of safety. Hi, honey, how are you? My husband gets so frustrated when he runs into the kindergarten teacher in the grocery store because she says, hi, Mr. Forky, how are you? And what she's doing is she's stuck in parent ease or mother ease. You do this automatically with kids because you know high-pitched musical sounds of safety. So I don't walk into patients and say, hi, how are you? But I do consciously take my vocal tone up a little bit. Hey guys, I'm so glad you're here. I'm so glad you've come in today. A little bit higher sends sounds of safety. We work at a disadvantage in medicine because our hospitals, all our machines have a low pitched hum, which is in the low register, which automatically is sending people into a bit of anxiety because they are perceiving that low pitched hum as a sound of danger. We also do this with our body language. We in medicine are notorious for folding our hands in front of us, maybe carrying a chart or some paper. But what we need to do is open up our bodies, come to the level of the patient and the family, and show them that we are demonstrating body language of safety. Wondering together also means that we share power or form a therapeutic relationship. I don't love the term share power, but I think you know what it means. Like, I don't think it's my power to share, but what we're doing is we're saying, look, I have some expertise in this aspect of medicine. You have expertise in your child and your family and your culture and your neighborhood. Let's think about this together. What's your understanding of what's going on? And when we do that, we are really showing them this curiosity, acceptance, respect, and empathy. And that's starting trauma-informed care. See, cute little acronym. I love one. if we do this for JR, if we open it up and we say, wow, it seems to us that you got so upset. Can you tell us more about that? He is angry that the nurse took his Doritos. He got so mad because she had no right to take them. They were not hers. All right, no new meds had been happening, but he was alone in the hospital. He was hungry and he was otherwise awaiting placement. When we start this conversation, we get more information, and that information begins to help us to understand why we saw this behavior, right? People don't just have a behavior out of nowhere. Behavior is the result of the thoughts and the feelings behind it. I don't have disruptive behavior when I walk in at the end of a day and see my kids have left dishes in the sink and not started dinner. I'm not behaving in a bad way. I have thoughts and feelings that are, I am overwhelmed and exhausted and I can't deal with this now. So I might scream at them and you might see dysregulated behavior, but it really has to do with the thoughts and feelings behind it. And so what we do when we wonder together is we get to understand what are the thoughts and the feelings that lead to the behavior. So we begin to understand in a new way. Okay. Right, Forky, I'm not going to get everything I need by just opening it up and wondering with my families. You're right. We do have to do more investigation. There's two ways in medicine we do that. The first way that we do all the time is surveillance. We ask open-ended questions. When you walk into any room, you might say, hey, what brings you to see me today? Hey, what's been bothering you? You ask open-ended surveillance questions. We can do that with trauma. We can open-endedly say, has anything bad, scary, upsetting happened since we last met? If you do primary care with a family, you can talk to the parents about what their experience of parenting was, of being parented was like, and how do they think they want to raise this child? Do they want to bring the same skills and tools into raising their own child? It's remarkable. When parents have good experiences, they say, oh yeah, it was fine. But when it wasn't, you will get some very interesting information. But if I have to pick one question, people say to me, what would be the one thing you would ask people? I ask people, have anyone come or gone from the household lately? That question will get you a huge amount of information about a whole set of circumstances. We also, besides surveillance, can do screening. But I would suggest to you that if we are going to screen for trauma, we need to screen not just for exposure, but also for symptoms. As I mentioned to you, there is a big emphasis on ACE screening. And I always think of that line from Princess Bride. You keep using that word. I do not think it means. What do you think it means? Those of you who haven't seen Princess Bride, I urge you to watch Princess Bride because it's just a great movie. But what the problem is with the ACE questionnaire is that it was developed to be a research tool in a population. And there have been a number of studies which have come out in the past couple of years identifying the fact that the ACE questionnaire has validity in populations, but not individuals. The exact ACE study was replicated where they tried to match the ACE score of the people who were initially in the ACE study to their health outcomes. And it doesn't match, right? This is validity in populations, not individuals. So it's not all that, it wasn't meant to be a clinical tool and it doesn't have clinical validity. These are questions about history, but it's a very limited specific history. We may not be asking about the things that are most important to the person that's sitting in front of you. There's no predictive value. The researchers used 4 as a cutoff for the ACE screener because of how it played out in their statistical analysis. But one person having an ACE score of 1 and another person having an ACE score of 7, there's not necessarily a difference in their outcomes. You have to get more information, particularly about whether they had affiliate supports related to those problems. And finally, it doesn't tell you what is going on for this particular patient, right? Like you're finding out what they experienced, but you don't know how they've been impacted. There's no symptoms identified. So it's not really a screening tool. And it may harm. There's a number of studies sort of saying people are objecting to being given a number. I am not a number. You can't define my experience this way. And that can disrupt the trust in the relationship with the healthcare provider and make the patient and family feel unsafe, which is the exact opposite of what we're trying to do with trauma-informed care. So I would suggest that it's not about summing the suffering, but it's about building the buffering. And we can do that more effectively if we screen for both exposure and symptoms. And we can look at mental health symptoms, those functional symptoms, post-traumatic stress disorder, developmental trauma disorder. We can look for developmental symptoms and we can look for physical symptoms. there are a number of great screening tools which ask about experience and then link that to symptoms. In particular, if you haven't seen this tool, this one was developed by colleagues at Intermountain Health in Utah. It takes the UCLA Post-Traumatic Stress Disorder Reaction Index and makes it much more user-friendly. You can see that you don't have to score it. You can just look at it and identify if people are identifying none or little symptoms or much and most symptoms. And in a cool way, they're grouped. So the first couple of symptoms are about sleep. The next set of questions are about intrusive symptoms, and the other symptoms are about avoidance. So you can see how patients are reacting. Fundamentally, developmental delay can be a trauma response, right? When you are constantly under threat, you prioritize the skills of survival at a cost. And the cost is to the use of the cortex. And so you have interference with developmental tasks that are dependent on the safe attachment and the use of the affiliate. So when you are doing developmental screening, you are looking at trauma symptoms as well. So linking that with an exposure question. I will say that I used to give this lecture and say, we don't actually have biomarkers that are being used in day-to-day medicine. There's a lot of research into biomarkers so that we can sort of say, hey, is this asthma particularly related to stress and threat? However, I've changed my tune, and I would direct your attention to a recent article by Dr. Shonkoff and Boyce, which came out last year in Pediatrics. And what they have identified is that there actually are a few tools that are pretty ready for consideration if you are interested in looking at biomarkers. There's some other ones that need further testing and some other ones that are sort of further down the road. But I think the use of biomarkers is inching closer to our actual clinical practice. Okay, let's think about Cleo, right? So her parents said she wasn't sleeping before the asthma attack. We wondered together and we got that information. But objectively, is there something we can do to find out more about whether trauma could be involved? And indeed, if I ask that favorite question I have, has anyone come or gone from the household lately? It turns out that we get more information that is relevant to Cleo's situation. Her grandmother recently left the household. She went to a nursing home, and grandmother was the person who had been doing Cleo's bedtime routine before. More than that, grandma left because she suffered a stroke. It happened at night, and Cleo had observed the ambulance coming and taking her grandmother away. Now, the parents were splitting their time running to the hospital and the nursing home, and the parent was increasingly stressed because thought she was going to lose her job because she was spending so much time trying to split herself in many pieces. So there was so much more for us to understand about Cleo's experience. And once we hear what's going on, what's really going on, we actually can treat it, but we have to stop and we have to validate and affiliate, reestablish that affiliate response. Say, look, I am so glad that you shared this with me, but I'm so sorry that this is happening for you. We need to take a moment to sort of say it out loud, to normalize what they're going through and to give words to this experience. And that's a critical first piece. There are things that we can do, some really great things that we can do right in our clinical settings, the outpatient clinic, the inpatient clinic. And we have some tools from the American Academy of Pediatrics to help you do that. This is a handout, which is available for download from the AAP website. You can get this, put it up in your office or up anywhere you're working, but it identifies the 3 R's, which are the first 3 things that you can do when you're working with a child who's experiencing trauma. You know, we have lots of little cute things that tell us the first steps to do in many diagnoses, right? So if I have a kid who comes with a sprain, I use the acronym RICE, rest, ice, compress, elevate. I don't go through the physiology of sprains. I don't have to know a whole lot more than rest, ice, compress, elevate. For trauma, you don't have to go through the whole physiology of trauma. You can say, let's do the 3 R's. The first R is to reassure. Let this child know that they are safe now. Cleo needs to hear from her mom and dad that I've got you, that what happened to grandma was scary, but you're here and we got you. And we reassure with words, we reassure with touch, we reassure with little tents that we put up in kids' rooms and heavy weighted blankets. We show kids that you are safe, you are safe, you are safe. The second R is for routine and rituals because these communicate safety and shut down the stress response. Bedtime routines, eating routines, daily routines, and family rituals. On Friday nights, we always watch a movie and eat pizza. When we see each other, we always do a fist pump. These show us that we are in this community of support, and it takes all those daily things and puts them on autopilot. When things are running smoothly, you know you're safe. And so this act of getting into a routine shuts down that stress response. I know you know about routines. I know you talk to your families about it, but remembering to bring it up again when there's been a recent trauma, critically important, because families get off routine. They lose the fact that they are not paying attention to the fact that that lack of routine is what's dysregulating the child. And regulation is our third R. Regulation can take many forms. There's a number of things you can do. What regulation means is that you're calming the stress response, number one, and then you're giving kids the language to understand the emotions that they're having so they can manage them. Okay. Again, why did you get up at 8 in the morning? So that you could hear me talk about mindfulness? I'm not. But what I do want to just point out for you, that you've heard lectures on mindfulness and these techniques like belly breathing and squeezing your muscles. But have you thought about the fact that what they are doing is stimulating physiologically parts of your body that are responsible for calming? Deep proprioceptive centers that are stimulated when you get a hug are part of our calming mechanism, right? So when you squeeze your own muscles, you're giving yourself a hug, you're stimulating deep proprioceptive centers. When you do belly breathing, you're stimulating vagal nerves so that that is also part of our calming mechanisms. When you do a mindful meal, you're focusing on swallowing. Suck and swallow is one of our most primitive, earliest calming mechanisms. A little tip for you. If you're in a meeting and it's getting stressful and tense, take a break, hand out bottles of water to everyone, because when people swallow, they calm. It is part of why every ritual in families and in cultures is around meals. It's a calming thing that we do together. So think about how each one of these isn't just kind of part of what you learned around relaxation, but there's a physiologic reason for it. Okay, what about feelings expression? Kids who experience trauma, kids like Cleo and JR, have been in situations of threat where they are feeling emotions, but they can't identify what it is, right? We have all sorts of emotions. We have embarrassment, we have shame, we have disappointment, we have helplessness. But kids who are experiencing a lot of trauma kind of there's three buckets: happy, sad, and angry. And we want to give kids basically more crayons in their crayon box, more ways to color and understand their experience. And so we need to talk to them about words for emotion. What you can do is you can have kids look at videos with you, look at the Kardashians and say, what emotion is she feeling? You can look at movies, look at books, and help kids to identify what are those emotions. And then if you felt that emotion, how would you handle it? Okay, one quick other point is the value of play. For the last time, Forky, I got up so you could tell me play is important. I know, I'm a pediatrician, people play. Yeah, they do. But what I didn't appreciate before I understood this literature is how critical play is for helping us develop that sense of self and sense of safety. Play is actually how humans and other primates actually begin to develop this neuroceptive sense of safety in others. It helps you to rewrite your maps of yourself and the world, and it helps caregivers and kids to attune and get in sync with each other so they can see those signs of safety in each other. When families are living under threat and in danger, they don't play. But play calms the stress response. And so we want to get our families back to play. And it is not all play, right? Not all play is the same. I recently was talking to a family where their child was just returned to them. The child had been in foster care and was returned to their care. And I said, the child was acting out. And I said, well, do you guys ever get to play together? And the caregiver said, yeah, we play. I take him for a ride on an ATV every day. So the child was 3. So that made me like a little crazy because I'm a pediatrician. But that also wasn't what I meant. I meant play that was face to face, smiling and talking with each other so we can read those clues from facial expression, from tone of voice, from body language. So things like blocks and Play-Doh and drawing and painting and games. We will use we have Child Life, and we will use Child Life to come in. And what Child Life will do with us is work with the parents on minding their P's and Q's. Parents who have experienced a lot of threat and trauma tend to do the Q's. They lead, they ask a lot of questions, they criticize. So with my young little boy who was acting out, I brought Child Life in and we said, let's color together. And as the child started to color in his 3-year-old way, the father said, "No, you're drawing it wrong. That's not the right color. And what are you trying to draw? That doesn't look at all like us." So he was leading, he was asking questions, and he was criticizing. What we want him to do is to praise, paraphrase, and point out, "Wow, look at the picture you're drawing. I'm so impressed. That looks like me and you and our dog. I can see all those pieces in there." Praising, paraphrasing, and pointing out. Why is this important? It goes back to the affiliate response. When kids hear and see these signs, they recognize that the caregiver is providing that affiliate support. Okay. But what about kids like JR? I mean, these are kids who are out of the box. They are in their lower brain. They are kind of out of control. How are you going to provide the equivalent of the 3 R's for someone who is totally dysregulated? Well, one of the first things you're going to do is you're going to think about what were the thoughts and feelings behind that behavior. What about this situation made him feel unsafe? What did Doritos that he had mean for him? What had he gotten Doritos from someone? Did he have a concern that he wasn't going to have enough? Kids who've experienced constant threat will hoard food, and it's not always because they've had food insecurity, but constant threat actually turns off feelings of satiety. And so kids feel hungry all the time, and they feel like they need to have food. If you think about it, it makes sense. If you're constantly being chased by a tiger, you have to eat all the time. So you want your satiety center shut off. But was it also that this nurse physically represented something to him? Was she in a role that had been threatening to him in the past? Was there something about the fact that he felt hungry when this happened? Was there something to the fact that he was having something taken out that was his being taken away from him? And were those fear responses? We also want to point out that the reassurance that we can provide to a child who's actively dysregulated is going to focus again on our affiliate response to them. We often talk about affect management. So you want to meet that child's energy. I don't want to talk to them as if I'm like working in a department store in the complaints department. I need to sort of say, wow, I am hearing so much energy, JR. I am feeling all this emotion. Can we think about what's going on for you right now? And try to understand the thoughts and the emotions behind that behavior. You're attuning and validating what he's feeling in that relationship. There's some other skills that you can use. Motivational markers mean that you want to find a reason why kids can calm. So if you can keep yourself safe, we can sort of take a break and get to see your mom. So you want to sort of get them to something that they can go to. Distract with calming mechanisms like listening to music, taking a walk, doing some deep breathing, coloring. But a lot of this relies on that child finding that sense of safety in those interactions. You have to be radically authentic, present in what you say and how you say it. Some people use the acronym MAP for mentalization, asking curious questions, and providing validation. Mentalization gets us back to that concept that people feel like they can use affiliate if they believe that you are looking at the world with their mind in mind. When you ask curious questions to say, wow, tell me more about this emotion, the way you're feeling. Tell me more about what happened just before you felt so upset. Asking curious questions that get to understanding and validating why the child behaved as they did. Of course, both JR and Cleo need a little bit more than we can provide in the hospital or clinic setting. And we need to refer these kids for evidence-based trauma therapy. These are therapies that specifically address trauma. They get it out of the lower brain and help work it through in the higher brain. Trauma-focused cognitive behavioral therapy, child-parent psychotherapy for young kids, or parent-child interactive therapy. They both work on that attunement or that parent showing that child that affiliate support. CFTSI, or Child and Family Traumatic Stress Intervention, is a really great therapy to prevent the onset of post-traumatic stress disorder when you've heard about a trauma. What you want to do is start this therapy within 30 days of a trauma. And what has been found is that you can avoid children developing PTSD or more, because what it does is it focuses on that caregiver working to understand what's happening for their child and providing affiliate supports. Eye movement and desensitization reaction therapy is EMDR. That's another great therapy. It does a lot of what TFCBT does, and it links it with a physical act of tapping your fingers. Many of our kids need developmental support or community resources, not just therapy, but making warm handoffs, talking to the family about, I am referring you here, let's talk to them together, or explaining to them where they're going, why it's important. Many people say to me, okay, but I'm a doctor and they just want medication from me. And I don't want to deny that, because that is ultimately what a lot of times people are coming to us for. The problem is that the answer can't always be found in pills, but we need to identify when and where it does work for us. So when people are coming in and they're saying this kid's behavior is out of control, or we have a problem and we need a med, I think what you want to do is you want to have a multi-step plan, and I am giving you permission to do this. Think to yourself, kids are tricky. This could be several things. Trauma is complex, treatment takes time, and medications are scary. You are allowed to think that, because those are all true. What you're telling the parent or the family is, look, it is hard to know if we're dealing with ADHD or we're dealing with trauma. It is hard to know if this is purely depression or if the experiences that she had in terms of that sexual assault is playing in and this is PTSD. I do know that trauma treatment works. And so we're going to get you connected with trauma treatment, and we're going to start that first and monitor. We also can think about a skill. If the family says, there's so many things wrong, I don't even know where to start, we start with sleep. Because when people are not sleeping, nothing else goes well. What is our clinical decision tree? If it's recent trauma, we can do a brief intervention right there in the office, talking about what happened, talking about expected responses of the child, talk about those 3 R's, and follow up. If we see some trauma-specific symptoms, we can address those behaviors first. For younger kids, we think about parent-child interactive therapy. If the child's behavior is the primary issue, we may think about dialectical behavioral therapy, which is behavioral therapy and not just trauma therapy. But if we have a kid who definitely is demonstrating that they've had a trauma and is symptomatic, then we're going to think about that TFCBT or those exposure-based trauma treatments. What about meds? If we have sleep problems and you've tried some trauma treatments and work at home, melatonin has demonstrated some efficacy for getting kids back on a sleep-wake cycle. And prazosin has demonstrated efficacy for kids who are having nightmares that are disrupting their sleep. Many times we see kids with anxiety and depression symptoms that are related not just to depression, but to PTSD. And so we can consider an SSRI, and in particular, sertraline is the drug that is most effective in the PTSD possible scenario. Finally, many times, especially we in pediatrics, are being brought kids, especially little kids, and people say this 3-year-old or 4-year-old has ADHD and we need you to start them on ADHD medication. What we are sometimes really seeing is kids who've experienced trauma, and we're seeing constant intrusive thoughts and hypervigilance. For those kids, you want to get them into EBT, but we can consider alpha agonists to help take those kids and kind of re-regulate that stress response. And alpha 2 agonists can have some beneficial effect. I'm happy to talk about these more. Never use benzos, never use second generation antipsychotics. Medication is a whole lecture unto itself, but I did want to mention it. Ultimately, we have wondered together, we have investigated, we have treated, but we need to not just stop there. We need to talk to families about the fact that we expect the child to recover. You know, when kids come to us and they've an ear infection and they've been up all night, or even a more serious diagnosis like cancer, we don't just say, oh, wow, it's pretty bad. We say, look, I see an ear infection, here's some antibiotics. I'm sure you'll be feeling better by 24 hours. And if not, you need to call me back. Or even if it's a serious diagnosis, look, this is concerning, but we have some specialists. I'm going to get you over to there. They are going to be the best for you. And I'm sure we have an excellent way forward. Providing that positive expectation of recovery is critical. And we forget to do it when we're talking to kids about traumatic exposure and symptoms. So trauma-informed care, we're providing safety with affiliate responses. We're wondering together. We're investigating with surveillance and screening of both exposure and symptoms. We're treating with some office-based or hospital-based guidance and a referral if needed. And we're always providing a sense of hope or a positive expectation of recovery. What did we cover in my quick 50 minutes today? We covered the fact that trauma-informed care means we do this work with families so they can be with their child promoting that affiliate response. We engage with words and body language and vocal tone, and we validate that caregiver experience to promote that sense of safety. We can do surveillance and screening for exposure and symptoms in these visits. We can introduce simple, practical techniques to promote that co-regulation of the child while providing it for the caregiver. And skills to address those trauma symptoms we can teach pretty quickly, just the way we do other anticipatory guidance. We may need to refer to evidence-based trauma therapy with warm handoffs for some of our patients, but we always need to provide that positive expectation of recovery or sense of hope. I have plenty of references. I give you a few, and I'm happy to stop here and to talk with you guys and answer some questions. So let me stop sharing and come back to you guys.
Thank you so much. I was permanently muted for a second. For everyone online with us, which there are quite a few people, please feel free to enter any questions or comments into the chat. In the meantime, can I just ask you, and then also maybe I can ask Dr. Webster and other people from Seattle Children's about the availability of resources for people who need therapy? Because I feel like we see this, I work in the emergency medicine, and we see this so much. And I, at least from my end, feel like the availability of therapy for people is limited right now. And I'm wondering about how that looks for you in Massachusetts, and also any tips for us here in Seattle.
So I can answer for Massachusetts, which doesn't do you a whole lot of good in Seattle.
I'm curious.
But I would say that there are more resources than you might think. There are certainly some in Worcester. If you guys go to the National Child Traumatic Stress Network website, that also can link you to show you some of the resources in your area. The other thing I will say is that evidence-based trauma therapy follows a protocol in most cases. And if you think about TFCBT, there are steps of TFCBT that follow the acronym PRACTICE. And P stands for psychoeducation, R stands for relaxation, A stands for affect management, and C stands for cognitive restructuring. When we talk about the 3 R's, when we talk about how you validate and talk about trauma, you're doing the first 4 steps of TFCBT. You can do that, and you can do that briefly, and you can do that effectively. So the kids do need to get to therapy, but you are already starting that process and letting the family know that that's what you're doing.
Thank you. I'm hearing that there's a question in the room. Emily, you can feel free to take the mic. Or maybe not.
Hybrid has its advantages and disadvantages.
I know. This is the first time we've done this. I'm going to keep going with the questions in the chat because we have several. And then Emily, let me know when you can break in. From Anthony Bui, one of our chief residents. This was a fantastic talk, Dr. Forkey. Thank you so much. As we start to think about the role of training general pediatricians, what would you recommend in terms of changes we should make to our curriculum moving forward? That's a great question, Anthony.
So we have been working really hard to think about how do we incorporate trauma-informed care into everything we do. It's not an add-on, it's how you do your work all the time. So I think part of what we want to do is we want to add trauma into every aspect of our care, right? We know that most kids will experience some trauma at some point in their lives. So to ignore it, we do so at our own peril. We are missing the diagnosis so much of the time, and then the family's frustrated, things aren't working, and it would be more effective to do our work that way. So a simple, like a quick way to say this is that if you hear about trauma, look for symptoms. If you see symptoms, think about trauma. That's sort of the overarching principle. So when you guys do morning report, add trauma to thinking about it. But then also thinking about some dedicated time that you're learning specifically about what are trauma physiologic reactions? How can I screen in my setting? What are the tools that we're using in our place that we find most effective for our clinic? And then what are the treatment options available to us right locally so that people feel comfortable like incorporating this right away? I will say trainees adapt to this actually far faster than the old people who've been doing it for forever, because they're the ones that'll have their own routine. And as you're learning and incorporating this, it makes more sense. So I'm really delighted to hear you guys thinking about doing this right in training programs. I will say there are a number of articles out there about how to incorporate it into training programs, one that we wrote about adapting a curriculum that we developed, but you don't have to use that. There are many other options coming into the literature now.
Thank you. That's a great That's a great perspective. And on a similar vein, can you talk more about supporting parents who are experiencing traumatic stress that is affecting their children?
This is actually a really important question. You know, when we have caregivers who are experiencing trauma, when we have caregivers who are dealing with substance misuse or postpartum depression, other mental illnesses, there's a really interesting concept that I didn't have time to cover, and I'm happy to talk about more because I know we're going to get to meet. Everyone who becomes a parent has changes to their brain so they can do that work, right? We used to think babies were cute, so everybody who was caring for a baby was going to be able to just do it because they're just so bloody cute. That is not going to do it from an evolutionary standpoint. And as it turns out, there's this really cool research that means that human brains change as you begin to parent. We talk, you know, I'm sure you've heard about some of the changes that go along with pregnancy and lactation, but there are changes in male brains and in brains of people who adopt just the same. And what it's called is the human caregiving network. There are changes to your brain. There are changes in your orienting, right? You become more alert to that baby and to that child. That's changes in the prefrontal cortex. There are changes in the amygdala that are related also to how oxytocin interacts with dopamine so that parenting becomes more rewarding. And if you think about it, parenting is not rewarding. Being up all night with a screaming baby is not rewarding to the casual observer. But when that baby is yours and they smile and makes it all worthwhile, that's because your brain changed. There are changes, particularly to male brains, that make them more empathetic. There are changes in the anterior cingulate cortex of males and females, but more in males because males are a little less empathetic to begin with than females. But those brain changes have to happen so you can parent effectively. Here's the interesting thing. Trauma, substance misuse, and mental illness, particularly postpartum depression, affect the brain at the exact same places that these human caregiving networks are supposed to affect. So families who are dealing with those issues are at a physiologic disadvantage. They're not just being mean to their kid. They physiologically are not able to do the work the same way. So coming with a sense of that physiology and understanding that is our job. In pediatrics, I am shocked that we don't learn more about this, because what we need to do is to recognize what our families are struggling with and address it from that perspective. I'm happy to talk more about that, but where you start is with affiliate. What is your experience of parenting and what is the struggle for you? Have that empathy to recognize that they don't hear the baby cry the same way. They don't feel the joy the way a parent would otherwise. And so this work is extremely hard for them. And you may not be able to solve every problem in a 15-minute visit, but when you provide that affiliate support in the interactions that you have, you become a resource to this caregiver so that they can get the help they need so that their brain can change in ways that are more effective. Certainly, they might need trauma-focused therapies themselves, and having resources for parents is great. I could go on about this forever, but recognizing the physiology of both trauma and parenting is critical. That was a way longer answer than you wanted, I'm sure.
That was exactly the answer I wanted. So thank you so much. We are at the end. We have lots of people saying thank you in the chat. We are at the end of our Grand Rounds hour. However, we have some extra time to continue the conversation, and I'm going to point those of you who are attending by WebEx to the chat where Emily has dropped in the link to the next meeting with Dr. Forkey, which I really, really appreciate the time we spent with you today. And there's more. So in 30 minutes, you can join the SCAN team and Dr. Forkey in another 90 minutes.